Hello everyone, Dr. David Warmflash here with another flash moment in medical science. Today we're doing part 2 of acyanotic congenital heart disease. Let's talk a little bit about, what happens on your examination in cases of acyanotic congenital heart disease. You're examining the baby. Well, auscultation. Now, really, echocardiography will reveal everything, and that's usually how the diagnosis is made. But on your exams, they'll ask you a lot about auscultation because there's some classic findings. Now, in an ASD, an atrial septal defect, you're going to get a murmur on systole, a systolic ejection murmur. Why is it during systole? Isn't this happening in the atria and stuff that's happening in the atria? Really, you're thinking about that during diastole? Well, not exactly, because what happens during an ASD is blood is moving from the left side of the heart to the right side of the heart. You're getting this extra blood coming into the right circulation. It's going to come into the right atrium, not only from the two vena cava, but also from the left atrium, which is going to then get overloaded with volume, which means that the right ventricle is overloaded with volume, and that means that the pulmonary artery is overloaded with volume, and that's actually what gives you the murmur. It's an extra blood going from the right ventricle in and through the pulmonary artery. But what does happen during diastole that you can hear is there's a diastolic rumble. So that's something also as a result of this messed up hemodynamics inside the atria. There's another thing you need to know about an ASD, about the sounds, is a split S2. The reason that happens is also because the lungs are overloaded with volume. So more than the usual amount of blood goes through the pulmonic valve and into the pulmonary artery. So then when it's time for the pulmonary valve to snap close, there's a lot of extra time until that happens because there's way more volume in there. So it takes longer for it to close, and when it finally closes, it's going to make a louder sound. So that gives you a split S2, the S2 consisting of the A2, the aortic valve sound, and the P2, the pulmonary valve sound. And P2 takes longer, so you get a split S2. That's something you should remember. Now, let's talk about a PDA, a patent ductus arteriosus. With this, here you have also a murmur. But what's really interesting about this one is that you have a murmur throughout the entire cardiac cycle. You've got it during systole and also during diastole, and it's called a machine murmur. Why do you have it the whole time? Well, because for the entire time, whether it's systole, when the pressure in the aorta is really high, or during diastole, when the pressure is lower, it's always higher than the pressure in the pulmonary artery. And that means you're always going to have this movement of blood from the aorta through the ductus arteriosus into the pulmonary artery. It's just it's more of it moving faster during systole, and then it kind of slows down during diastole. So it's more like a I like to think of it in terms of those horrible leaf blowers where the worker's always kind of revving it up and down, but it's always on. And once you hear it, you'll never forget it. So another thing we got to always think about, another malformation, which is sometimes connected with the PDA, is a coarctation of the aorta. We're going to talk about the two together because in some situations, especially when it's a baby born, especially a premature neonate born where there's a PDA, you can have that together with coarctation. Now, in terms of treating PDA, also if the baby is born preterm, that makes it fairly easy to treat because it usually will respond to NSAIDs like indomethacin or ibuprofen. You remember from your study of pregnancy that the pregnant woman is not supposed to take NSAIDs, especially during the last part of pregnancy, because what that can do is it can cause premature closure of the ductus arteriosus, which would be really, really bad if that happens during fetal life when you really need that open because of reasons why we discussed in the beginning about the fetal circulation. And what makes it actually stay open is prostaglandins. And there's a prostaglandin called prostaglandin E1, which sometimes you want to actually give that to keep the ductus arteriosus open on purpose. You can hear why in our video about cyanotic heart disease. There are a lot of cyanotic heart disease situations where you want to keep the PDA open, but that's for the other video. But just keep that in mind. You give prostaglandin E1 for that. The opposite is to close it, and if you can get it done early, it will often close with NSAIDs, which work against prostaglandins, and that will be more likely to work in a preterm, because the reason why a PDA, why you have that, why the ductus arteriosus stays open, is because of the prematurity. It just didn't get the memo that, hey, it's time to transform into the ligamentum arteriosum. Some other things that can keep a ductus arteriosus open, a lot of different infections like torch infections in the mother. Torch stands for toxoplasmosis, other, which could be a lot of different infections, rubella, which is the real important one, and cytomegalovirus, CMV, and herpes simplex. You really have to know the rubella part, because maternal rubella syndrome, a component of that is a patent ductus arteriosus. You really want to avoid rubella in the mother. Mothers need to be vaccinated against rubella virus. That you get as part of a combination of live attenuated vaccines, and because they are live vaccines, she's not allowed to get that while she's pregnant, so she has to get that before she's pregnant. But do keep that in mind, because often on the exams they will throw rubella in there as a hint for why there's a PDA. Now, if it doesn't respond to drug therapy like NSAIDs, then you need to do surgery, and surgery is typically the answer with all these deformities. With VSD, where it has to be closed unless it's really tiny, same with an ASD. And you also need to close them if they're big, because you want to avoid Eisenmenger syndrome, which is something that can happen also with a PDA. And in particular, it can happen in a PDA where you're going to have a lot of movement of blood volume from the aorta into the pulmonary artery, and therefore through the pulmonary vasculature. Because what happens there is that the lungs say, whoa, there's all this extra volume, so there's all this extra pressure. Let's deal with that by fibrosing and getting stronger and harder, so the pulmonary vasculature kind of hardens up and causing pulmonary hypertension. That translates into high pressure in the pulmonary vascular system, just like it was high pressure during fetal life for a different reason, because the lungs were all collapsed. And that will eventually translate into high pressure in the right side of the circulation, in the right ventricle, in which case it could eventually get to the point where pressure on the right side of the heart starts winning over the pressure on the left side of the heart. There's actually higher pressure on the right side, and the shunt direction, instead of going from left to right, it starts to go from right to left, a reversal of the shunt into a cyanotic shunt. That's what Eisenmenger syndrome is, and it's a very dire consequence. It's something that you want to avoid. Now, coarctation of the aorta This is when you have this kind of constriction, and it usually happens very close to the ductus, which is either a ductus arteriosus if it's still open, or it's the ligamentum arteriosum. Same location, and often these are characterized based on whether it's preductal, meaning if it's proximal to the ductus or the ligamentum arteriosum, or if it's distal to that. Now, in a congenital condition, when this happens, when this shows up in a newborn, very typically this is a preductal coarctation. Now, we'll talk about the difference in a second. Let's just talk first about who gets coarctation. There are a couple of situations that you should know about. One of them is Turner syndrome. Turner syndrome is when you have 45 XO. So there are 45 chromosomes instead of 46 chromosomes. This is called a female. It's phenotypically a female, but there's only one X chromosome. There's no Y chromosome. It's female because it's a lack of a Y chromosome. No Y chromosome. That makes the person a female. But you get the webbed neck. You also get very extremely short stature. And also associated that with is coarctation. Not necessarily, though, with the PDA, but it can occur with PDA. Another risk factor for coarctation is the people who have a bicuspid aortic valve. That tends to show up in an adult, but just remember those two things can often occur together. Now, how about this difference of the coarctation happening before the ductus or after the ductus? Well, most of the time it's before, and when it's before, that means where's the pressure going to be? The pressure is going to be, because you have a constriction, everything upstream from that constriction, from that coarctation, is going to be under very high pressure. Now that means everything in the upper body, the head, the upper extremities, everything all the way up through the subclavians, which feed the upper extremities, is going to get a lot of pressure. But if the ductus arteriosus is open, and this coarctation is ahead of the ductus, you're not going to get much pressure into the aorta from the ductus downward. And that means what happens to the pressure in the aorta from that point? It's low. And that means if your blood inside the pulmonary artery, you will want to go actually through the ductus arteriosus, the same direction that it goes during fetal life, because you got this, hey, there's this low pressure zone in the aorta, because everything in the aorta downward from the coarctation. In that case, even though this is a lecture about discussion of acyanotic congenital heart disease, this is a situation where it can become cyanotic, but differentially, only in the lower body, because what you'll have is blood from the right side of the heart going in through the pulmonary artery, is going through the ductus arteriosus, and it's not going up, it's going down through the abdominal aorta, and it's mixed now with the oxygenated blood. So you got that purple kind of blood, which is really blood that can cause some amount of cyanosis, depending on how low the saturation really is in there. So we really got two situations where these acyanotic conditions can lead to cyanosis. One is Eisenmenger syndrome, and the other is where you have coarctation occurring together with a PDA when you have the coarctation proximal to the PDA. Now, when the coarctation is distal to the ductus, it's usually not a PDA, it's usually just the ligamentum arteriosum. In this case, you don't have a cyanotic situation where you get the blood mixing, but you do have a situation where you have high pressure, superior, meaning proximal to that coarctation, and very low pressure below it. Here's a situation where you're going to get high blood pressure, hypertension, if you measure it in the upper extremities, and very low blood pressure if you measure it in the lower extremities. You won't get the cyanosis necessarily below, you just won't get that much circulation at all. And because the pressure is extremely high in the upper extremities, this puts the person in danger of things like baryaneurysms in the brain. And also what's happening is the kidneys, because the kidneys are in the lower part of the body, they don't know that the pressure is so high in the upper part of the body. And this is actually something that's kind of analogous to what happens during space flight when there's weightlessness, when the blood is actually up it's in a cephalic direction up toward the head, because there's weightlessness, so the body doesn't realize that it's in a gravitational vector because the vectors are canceled out. It's a very similar thing that happens. But in this case, it's just because of a physical obstruction. That coarctation is causing all the pressure to be up in the head and in the arms. You can get those aneurysms, but also the kidneys now think you don't have enough circulation. They're going to say, what are we doing? There's not enough blood here. So they will secrete erythropoietin, and the person will make more red blood cells. That's also something that happens in high altitude, which is also something worth mentioning. High altitude is yet another risk factor. Being born at high altitude, where the environment naturally has a low partial pressure of O2, this is another risk factor for a patent ductus arteriosus. So with PDA, here you got high altitude, you got rubella, think of congenital rubella syndrome, and you got Turner syndrome. So put together all the different risk factors and put together the physiology and get this thing as a concept. And this is also really important when you talk about cyanotic congenital heart disease, and eventually it'll all come together for you. You won't really have to memorize that. And that'll be enough for the discussion today. This has been Acyanotic Congenital Heart Disease, and we'll be back in a flash with another video.